Okay, everyone, good evening. I'd like to say that we are now live, so behave yourselves. Right, can everybody introduce themselves, please? Because there's a couple of people we're not sure who they are at the end. So if everybody introduce themselves, and then we'll know who everybody is. Okay, my name is Agatha Kajina, the councillor and the chair.
Jacqueline Totterdale, Chief Executive of Epsom and St Helier.
Good evening, my name is James Blythe. I'm the Managing Director of Epsom and St Helier University Hospitals Trust.
Councillor Max Austin.
Councillor Eleanor Cox.
Councillor Lakshmi Atara.
Councillor Caroline Charles.
Councillor Simon McGrath.
Thank you all very much. Just thought it would be good if everybody introduced themselves, so your names can be written down that you were here. Okay, right. We're going to take the building your future hospital program first. Okay, so if you would like to start.
Thank you, Chair. I will start. I've been asked to give a very short introduction and to take the papers as read. So we've been asked to give an update for a little bit of context. Members will be aware that in July 2020, the committees in common of the then clinical commissioning groups for the NHS in South West London and Surrey approved a proposal relating to the reconfiguration of acute hospital services run by Epsom and St Helier. And that proposal was to retain 85% of services at the current Epsom and St Helier sites, but to consolidate 6 of our acute inpatient services to a new specialist emergency care hospital on the Sutton Hospital site, which had earmarked central government funding to be built. Since that time, we have been working as part of the National New Hospitals Programme to start developing the detailed plans for that hospital. We have also been working very closely with Sutton Council in terms of the planning and the access requirements to the new hospital. And we've also continued to work closely with the NHS locally in Merton and Sutton and the relevant area of Surrey to ensure that our plans remain fully aligned with local health and care plans and local strategies tackling the wider health needs of those populations. We are part of the government's National New Hospitals Programme, which is committed to the construction of 48 new hospitals. And as part of that programme, we are working closely with central government to ensure that those new hospitals are built in a coordinated way. Obviously, this is a major national infrastructure project and needs to be taken forward in an aligned way. But it is important to say that we retain that commitment to this scheme as part of that wider programme. However, working as part of that wider programme, as well as dealing with some of the delays that have been a function of the last couple of years in the NHS and wider society, means that while we had hoped to open the new specialist emergency care hospital in late 2025 or early 2026, we now know that it will not be ready until 2027 at the earliest. But we are continuing to work through those detailed plans with local stakeholders and also with the National New Hospitals Programme. And we will continue to work with local stakeholders on the details. So as we develop the design for the new hospital, as we continue to work through how services will be organised between the new hospital and the current Epsom and St Helier sites, we will continue to engage with local stakeholders as we do that. So I was proposing to stop there, Chair. I'm happy to take any questions. Either myself or Jacqueline, our Group Chief Executive, are here tonight to respond to questions.
Thank you. Before we carry on, I got a bit ahead of myself. I got excited to hear what you've got to say. We have to do the official things like asking if there's any absence or minutes of the last meetings. Have we got any apologies or anything? Minutes of the last meeting? Yep. We'll do that next. Declarations of pecuniary interests. Nobody. Minutes of the last meeting? Are they agreed? Right. Thank you.
Can I just ask for an update? Oh, sorry.
Yes, do. Right, we can now get on. Jacqueline, is there anything you'd like to add to what you just said?
No, not at the moment. Thank you. Sorry,
Okay,
my
then.
voice is going.
Right, are we all ready for questions?
Yeah, I just obviously like to start in terms of obviously the overall budget. Yeah, the budget for this new hospital was 500 million. I understand it's been reduced to 400 million. Clearly, obviously, we have incredibly high inflation at the moment at 10%. Some forecasts put it heading towards 20%. We obviously know construction costs are obviously impacting in terms of development. Can you give us an update in terms of obviously the overall budget and how much of the leeway is being accounted for on that? And the other obviously thing I'd like to raise, you said obviously you've been in talks with Sutton Council about the proposed new hospital. Have you got any kind of timeline for that in terms of the submission of the planning application and when it is likely to be determined by that council? Because clearly, obviously, you know, without that determination, work cannot even start. And you obviously said you hope to have the hospital opened 2027 at the earliest. You know, originally obviously it's late 25, early 26. Is there much chance that this program will slip further into 2028, 2029? Yeah, I'll obviously be interested if you could provide further information on that.
Thank you, Councillor. So just to try and respond to those points in turn, it's not correct to say that the budget was cut by £100 million. We've never received an instruction that the budget is cut by £100 million. We have continued to liaise with the National New Hospitals Programme to ensure that they have the information about the costs of our scheme, about the costs of dealing with the implications of COVID for our scheme. And obviously, we continue to keep a close eye on construction inflation. Now, one of the things that the National New Hospitals Programme is looking to do is to look at collective approaches to procuring and in some cases constructing these new hospitals as much as practicable. And the intent of that is to look to offset some of these inflationary pressures and ensure that the taxpayer gets good value for money. So I don't think it's actually possible for us to say at the moment what impact inflation will have on our scheme, because with the national programme, we're taking active steps to try and mitigate that impact. What we do know is that we are very clear about the clinical model and about the level of capacity that we need to provide. And there's absolutely no pushback on that from the national programme. So that remains a fixed point throughout the programme. We don't have a clear date in terms of planning. I mean, I hope that we will have further engagement with the planning process before the end of the calendar year. But again, it very much depends on our work with the national programme and making sure that we move forward in a consolidated way. And I would say that that does then have a potential impact on the overall timescale. I mean, one of the things that we're very mindful of is the fact that there are also severe constraints in the overall construction market at the moment. And again, that is one of the reasons why we're working really closely with that national programme to try and offset that wherever possible. But of course, I think it would be far too premature to say at the moment that we are not susceptible to further delays. I mean, with the constraints in the construction market and the wider economy, we'll need to continue to work really hard to get this delivered as soon as possible.
Follow up in terms of that, can you obviously give some examples of offsetting inflationary pressures? It would be good to have some concrete examples of what you're actually doing, because it seems obviously quite a generalized statement.
Yeah, so some of the things that we are engaging with the national programme on are about whether there can be some common design and manufacture elements, whether we can, have a single way of, designing a hospital room, of how bathrooms fit within hospital rooms, because obviously where we do have single rooms, we would look for them all to be en suite. Whether there's a consolidated design for, for example, for a ward, whether some of the digital elements of the new hospitals could be designed and purchased on a consolidated basis as well. I mean, I think these would be core expectations of any big national infrastructure project. If the Exchequer is going to go and buy a significant amount of public infrastructure, it is going to seek to get good value for money for that, and it's really important that we engage in it.
Thank you for that. Can I just ask you, on the where are we now, page 35, has there any significance to or in terms of delay with you asking for more upfront investment so that you can submit planning applications?
Yeah, so we have, that there are costs to getting ready for planning, and we need capital to actually fund those costs. What's really important within this is that the costs of developing the scheme don't come out of our day-to-day running budget. So we are not making a relative decision between running the hospital and developing the scheme, and that's why we treat it as capital and we get central funding for that. So we've been given a certain amount of money this year, and that's based on an expectation that we'll move at a certain pace, because we know that this needs to happen. I mean, because of the challenges that we've set out in the pack, we want to go faster. And we've submitted an application to the national scheme to go faster on certain elements, but that means that we need more funding now to progress with some of those planning elements, and actually potentially moving into some enabling groundworks that could happen now and would shorten some of the timescales later on in the programme.
Yes, I just want to ask, I might be missing something here, but you say that 85% of the people who need care will still continue to be treated at St Helier Hospital. So presumably the other 15% will be treated at Belmont. So why so few patients at Belmont, and why can't all 100% be treated at St Helier?
I think this very much comes down to the case for change, to be honest. So the case for change is based on consolidating the 6 major 24/7 inpatient services where we need to consolidate in order to have the workforce to be able to run them effectively and be able to run them in modern and fit for purpose state. Now, by volume, they are only 15% of the patients, but actually they are the services that need that consolidation, that 24/7 consolidation. And there is really no way of running those services to modern standards and in modern estate, and with the workforce that we have available to us, without doing that from a single site. So what we've really sought to do is say, what are the things that have to be done once for our catchment, for all of the people that we serve, and they are those 6 inpatient services and a small number of the services related to them, and that's largely the inpatient beds for people who are acutely unwell. But right from the outset, one of the principles of this scheme, and it's one that we've held to throughout, has been that we should retain as much care as possible on a local basis, and that's the 85%. It's the urgent treatment centres, the diagnostics, the outpatients, keeping all of that as local as possible. From a healthcare planning perspective, in some ways, it would be easy to say, you just move everything centrally. It would, it would make some of managing the workforce a little bit easier, to be honest. But actually, we know that what's important to our local populations and what's important to providing the best possible model of care is that we consolidate where we really need to get the standards, to get the workforce, but we retain as much as possible locally. And that's been the reason for that split within this model.
Hi, so thank you for your updates there. Just wanted to ask about views from residents in the area. Can you just provide how you've collected those and what the general consensus view is?
I probably can't do justice to the huge amount of work that was done during the consultation process. So the lead up to the decision that was made by the CCGs was a very extensive consultation process. It was given sort of very high praise by the Consultation Institute, and that looked at extensively at residents' views from right the way across the catchment, and it did it through public meetings, which in a previous role I attended many of. It did it through focus groups with specific population groups. It did it through surveys as well. There was a very large survey that was undertaken as part of that consultation, and all of that is summarised in quite a lot of detail in the original decision-making business case and consultation outcome. We have set up a patient panel, and we're using that patient panel to find local service users to engage on specific questions that we need to ask as we continue with the development. So we're very much looking to continue with the huge amount of work done to get to the decision on the configuration, but actually that work continues for us as we continue to progress the details of the hospital.
Am I able to ask a follow-up? Yeah, so also just wanted to ask around staff, if that's all right as well. So I presume that the majority of staff will have been given the option to transfer across, or how will that be managed?
So there is no risk to the employment of any of our staff from this. So it will very much depend on where you work. So for staff who work entirely in an outpatient or diagnostic service, it's very unlikely to affect them. For some of our clinical staff, it will mean that their job 100% relocates to specialist emergency care hospital. For some of our staff, it will mean that they're working on a split. So some of our staff might have some elements of their working week on the Epsom or the St Helier sites and some at the Sutton site, and actually will rotate between the two depending on what they need to do on a day. I mean, I would say that speaking to staff, and if you look at the evidence from the consultation, there is overwhelming support from our staff, because they work day to day in the very challenged environment in our hospitals, and really they're crying out for this. They're crying out for the consolidation that means that we have enough of the right workforce in the right place, and really to be in that modern and fit for purpose environment. That is, hugely important to us in terms of retaining people and also recruiting and attracting people for the future.
Yeah, thank you very much for your presentation. I just wanted to say that we in Mitcham and Morden also carried out a consultation, extensive consultation, and had lots of conversation with staff and everything. And it seems to me that we've come to very different conclusions, where we felt that Mitcham and Morden has a large percentage of very poor residents who rely on the services of St Helier Hospital, and yet their voices seem to have not made a real huge impact, that you chose to make a final decision to build the bigger hospital at Belmont, where there is a more affluent population. They may be aging, but they are much better off than the people in the residents in Mitcham and Morden. So, while I agree, I saw the hospital and it definitely needs to be rebuilt and we need a new hospital, but it's difficult for me to sort of justify the conclusions that you have come to and the conclusions that we in Mitcham and Morden have come to. I just wanted to state that.
I think firstly, while we absolutely support from a hospital trust perspective, we absolutely support the decision that was made, and we do think it was the right one. It is important to say that it was made by the commissioners for South West London and Surrey, and that was it wasn't based on the needs of people in one particular area. It was based on the needs of the whole catchment, and it was about how the whole catchment should be served. And I think that what we are very mindful of is, with the model that we have consolidated the things that, for the reasons that I've set out, needs to be consolidated to provide a modern and fit for purpose service. We have retained as much as possible the 85% on the existing St Helier and Epsom sites. And we remain really committed to working very closely with wider health and care services in Merton and Sutton, and indeed in Surrey, because what the successive reports that were commissioned as part of that original consultation told us is the things that really determine the outcomes for people who are living in deprived communities and who have health inequalities challenges are not so much, the precise details of where an acute hospital service are, but more how services are provided outside of hospital, for example, primary care and mental health services as well. So I think that it's really important to us that we retain as much as possible locally, whilst delivering on that core reconfiguration that gives us that sustainability and that workforce and that environment for the future, but also retain that link to local services. And also we believe that for the St Helier site there will be some flexibility in the future. So if we want to look to develop more local services on the St Helier site, working with primary care and working with mental health, that is also something that we can look to do. And we've got a number of years to continue to progress those discussions.
Thank you. I was very struck last week. Some of us were invited by Jacqueline and Dr. Suckling to visit St Helier, and I was very struck by what we saw there and the strength of feeling from the doctors and clinical professionals that we spoke to about the new hospital. One of the things that occurred to me there is there does seem to be an awful lot of misunderstandings about the new hospital. For example, quite a lot of people think it won't have any urgent care services, whereas in fact that it will. The reference earlier to the cut of £100 million, which I've certainly heard elsewhere, and is helpful to hear that that's you haven't been told to cut the cost by that amount. And I wonder if you're happy that there's enough that you are doing in terms of community communication and community engagement to make sure that some of these misunderstandings are dispelled, because it sounds to me like I know we all know there are these misunderstandings out there, but there's more that could be done working with Merton and working with the community to make sure those are dispelled. My other question was about the same issue that Councillor Gould raised, which is on page 35 of the presentation. There's the thing about the upfront funding. And I just wondered whether, if you don't get that funding, is it likely to be later than 2027? And if you do get it, is it likely to be earlier? So, what kind of difference does that make? Because are we talking about, a lot of money? Or it doesn't. That sounds like quite an important thing to persuade the government to get on with, and let us have the money to get on with the decision and the planning. Thank you.
So it won't be any earlier. If we don't get more, then there's more chance that it could slip. To answer that question in a very straightforward way, I mean, the 2027 is us looking at how quickly we can do things now in terms of the planning, in terms of the enabling works, and in terms of the construction. And again, part of the work that we're doing with the National New Hospitals Programme does allow us to look at, their view is that actually many of the construction elements can be speeded up through some of the sort of central procurement and manufacture, as opposed to a sort of bespoke, bring a contractor on site, design a hospital and build it in the traditional way. But all of that needs working through. I think it's really interesting in terms of the communications. We feel that we did an awful lot around the time of the original consultation, and we've continued to put out newsletters. We have a newsletter that goes out to stakeholders. We've got our people's panel that we spoke to as well, and many of the senior staff in the trust and the wider hospital group have continued to attend meetings and give updates as well. There are a number of, I'd say there's a number of narratives around the scheme, and we will continue to work to give our perspective on it. If there are opportunities to provide more regular updates through forums within a local area, we've done resident association newsletters where they're available to us. We've done all sorts of sort of local forums. So if there's anything that any individual council or stakeholder wants to suggest that it would be helpful to get an update into, we're very happy to do that. And I guess it's about tailoring it to what works for a particular local community.
I'd like to ask something. Did you say that 500 million was never mentioned? Because we went to a few meetings and it was surely mentioned.
No, the 400 million,
No, it
which
was
is
500, I think I've got sheets of 500 and something
no,
million.
no,
And then 80 million was going to be given to St. George's
Yeah.
to ease it. It was 500 million.
so,
So I can't understand how all of a sudden we're being told it wasn't. If I could find those sheets of paper that was on, I'll find it and bring it in, because I can't understand. We were told something at the time, and now we're being told something else, and now it's been denied as if we didn't know what we're talking about. But it was told 500, I think 515 million, and I know it said St. George's will get 80 to ease whatever it needed to, they wanted it to do.
Look,
Now,
may I clarify, Chair? So 500 million pound was the original allocation from central government, and that is the case. I think the councillor's question referred to 400 million pounds because there was a story in the Health Services Journal that said that, or that inferred that schemes had had 100 million pounds taken off them. My response was saying that we never had communication from central government saying 100 million pounds had been taken off the scheme. Our allocation was never reset from 500 million pounds to 400 million pounds. So I absolutely recognise 500 million pounds as a number, and I agree that is the number of the original allocation. But my response was saying that we've never been given a smaller allocation of 400 million pounds.
and then you must disperse the rumours, because it's a very wide rumour that everybody's heard it, even the media was spreading it. So you can't expect people to expect anything else, really. And I just feel that we went along to the consultation. At the consultation, we were told the preferred hospital was Burman. We weren't listening to which one people wanted. A lot of people didn't agree with Belmont being the place where it was being built, because when you calculated everything, you only got an extra 2 beds or 3 beds or something like that. And all that money for an extra 2 beds, that's a waste of money when you can actually build something better on at St. Helier. So saying that this is what resident wants and this and that, it's not what residents want. Might be a few residents want, but the resident actually went to those meetings were not listened to. They were not listened to. We went to several of those meetings, and what we were told was the preferred hospital was Belmont. It wasn't, oh, we're deciding which one. We were basically told it was a done deal.
Oh, yes, I've got a couple of questions. You're talking about funding, and obviously that money is there, which is great, 500 million or whatever it is. But what I want to know is, you're saying that this Belmont Hospital wouldn't be ready till 27 or 28. So that's like 5-6 years away. So if we've got that money, why can't we put it to St. Helier Hospital now and get that upgraded now? So we've got something today. Why do we have to wait several years?
Because it's not possible to upgrade St. Helier and deliver the objectives that we need in terms of creating that environment for inpatients. I mean, you've seen the site. It is a set of 1930s concrete walls. We simply cannot. First of all, there's the issue about where the specialist emergency care hospital goes to serve the whole catchment, where the CCGs have made a decision, and that decision is the Sutton Hospital site at Belmont. But even if because one of the options that was in consultation was to build the specialist emergency care hospital at St. Helier, even if that option were to be taken forward, we would still have to build a brand new St. Helier. You can't upgrade St. Helier. It would need to be totally rebuilt. And actually one of the, although it would have been, if that was the preferred option, it's something we would have needed to do, is actually to do that St Helier, to build it where it is at the moment, you would have to put basically a whole temporary hospital onto the site, knock it down in stages, and then, so decant it and then rebuild it. So if anything, to sort of upgrade St Helier to get the objective that we want would be more complicated than building on a site where we can basically just sort of start again. So so I think that it's really important to say this is not about an upgrade. To get what we need, it is a total rebuild or a new build, and that would be the case regardless of where it was.
Yeah, the other follow-up I wanted to ask was, you were saying that people are being consulted by newsletter and by these panels. Well, I'm a new councillor. I've only been a councillor since May, but I've not received any newsletters or been invited to attend any panels. So I think it's really important, because I'm actually in a new councillor for a ward that is right next to St Helier Hospital. So a lot of the residents that I'm serving really need to know what's going on.
Take that feedback back to the team. That's helpful. Thank you.
I just wanted to say that we didn't say that the new hospital has to be built on the current St Helier site. There's a lot of land opposite. I know there's a covenant on it, but that is where a new one could be built quite easily. But anyway.
So yes, so I just wanted to add a comment that I agree, certainly in a professional capacity, completely understand your point around construction costs would be much higher to and it would cost taxpayers even more money to rebuild on the existing site. So I do understand the logistics and the cost implications of rebuilding elsewhere. I also wanted to ask about the view of the doctors, because I understand actually a lot of this is driven around talent, and what we want are our residents to have access to the best and most highly skilled, talented staff. Because if we can attract the right talent into the hospitals, our residents will get the best care possible. So I wanted to ask more about the views of the doctors and of the staff around where they would prefer to work.
So our consultant body were extremely heavily involved in the development of the original proposals. Many of them came out and supported the public meetings with us and helped us explain the options and why change was required. I speak to all of our senior doctors, all of our divisional and clinical directors every month. We have a sort of whole meeting and we talk about this scheme in detail and where we are with it. And what they consistently say to me is, that this continues to be absolutely required, and their concerns with too much further delay are about how we continue to sustain services and continue to attract people. Because I also sit on most of our consultant interview panels, and the fact that we have this scheme, the fact that we have the plan to put this scheme in place, is actually supporting us to continue to attract particularly consultants at the moment, so that when we do need to provide a 24/7 service, we actually have enough people to do it on a rota, and they're our staff. They're substantively employed. They're not locums. They're not temporary staff. They're our consultants, and they are there to provide that 24/7 service. But that recruitment is very much predicated on us getting to this place where those 6 major services are able to sit in a modern fit for purpose building and on a single site, because actually that is the thing that will allow our doctors in the long term to provide the very best care. And it's not just our doctors, it's our nurses, both our ward nurses and our specialist services, and the huge therapist, biomedical scientist, pharmacist workforce that we have as well. I mean, all of those clinical professionals that go into supporting our patients, where it's about acute inpatient services, they are all increasingly scarce skill sets to recruit to. There's huge competition to recruit people into them, and being able to provide that environment and that consolidated hospital is an enormous part of attracting them.
Thank you. And I'll just add that, I certainly think that sometimes change can be frightening, but I certainly personally see the benefits of a new facility that would attract talented workers, talented staff, providing the best possible care to our residents. So thank you.
Thank you very much for your presentation. I had a question around your digitization or your digital strategy. I appreciate this is about physical hospitals, but the hospitals of the future, or the treatment of the future, is going to be transformed by digital innovations, technologies. And I was interested in your the mention of the digital hospital as being an impact of COVID, but obviously NHS, telehealth, etc., and a whole separate debate, which I'm sure you don't want to go into, around access to patient records, which I'm probably well away from the scope of this discussion. But I'd just be really interested to hear your view on what you think a digital hospital will be. We obviously have this money for various purposes, and I'd just be interested if you could expand a little bit on your digital strategy. It's something I personally find very interesting, but as I said, if we're talking about building hospitals of the future, it should take into account that the great advances and efficiencies that can be made through digitization.
So I'll start. I'll bring Jacqueline in because I think St George's is a bit further down the road of digitisation than Epsom St Helier. So one of the supporting proposals that goes alongside this is that we are in the early stages of implementing an electronic patient record. So at the moment we have a patient administration system. It largely gives you the demographics of a patient and where they are in the hospital. It allows you to order some things, but our notes are paper. So we are in the sort of 2 to 3 year process to move to digitizing all of our notes and having a fully electronic patient record. And that is going to be a shared domain of a system called Cerner, which we're going to share with St George's because they've already implemented it. So we can build on their implementation. And then a lot of the infrastructure and the equipment that we have in the new hospital will be automatically linked in to that electronic patient record. So it is now possible to get medical equipment that will give you your results, your critical readings, etc., directly into the patient record. So there's not even the job of transcribing from a machine onto a digital record. It is done automatically for you. It massively helps in terms of managing patient flow. It massively helps in terms of managing the critical status of patients, whether they're deteriorating as well. So we are working to have as much as possible fully digitized hospital. And again, this is something where the expertise of a national program is really helpful, because actually doing this as a larger scheme allows us to buy and design at scale, rather than each one of 48 schemes going out and doing something slightly different. So again, it plays into that. But I wondered whether Jacqueline.
Thank you. I'll try and speak. It's revolutionised St George's in terms of patient safety as well, because we used to have all sorts of notes all over the place, trying to find the record for the patient. When they last came in a set of notes, sometimes it's quite challenging. So, and it brings all, as you say, all the bits of that what's happening to that patient, whether it be about drugs or tests, together, so decisions can be made very easily. It also means that our doctors actually can log on from home and see you actually for patients if they need to, so they can advise while looking at the patient's notes. And I think when we take it one step further, we're working across the whole of the NHS actually, but particularly in South, but also in South West London, about the virtual ward, which is about how we keep more patients at home. I think about my career in the health service. It's been 40 years, and I remember when we used to keep people who had a hernia in for a week. And now it's a day, and in fact, it's not even a day, it's a few hours. We do hip replacements and people go home in a couple of days because we've cracked pain relief and we get better at giving anaesthetics. And this bit is about the emergency care patient, where actually they can safely be held at home between an acute hospital and the community team, and we can monitor them at home. So that all plays into how do we keep people nearer home using what is actually not brand new technology. This is all technology that we're now picking up and beginning to use to keep patients safe and to look after them nearer at home.
Thank you, Chair. I just wanted to comment on a couple of things that have been mentioned earlier. We've heard the discussion about, is it 500 million or 400 million? What steps has the trust taken to put right the article that appeared in the Health Service Journal? Because if it's wrong, if it's inaccurate, then what have you done to tackle that? And we do know that inflation is currently running rampant. I understand that building inflation is increasing at a rate above that of the rest of the economy. I also wanted to raise the issue of health inequalities. I mean, the NHS makes much of it, and it's on page 32. There's this desire to reduce health inequalities. I represent the ward that is closest to St Helier Hospital in Merton, and it is a deprived community. And when people say that they're tackling health inequalities, the people I represent say, if you're serious about tackling health inequalities, why are you moving a hospital that's been here since the end of since before the war, was started before the war, and moving it to one of the most affluent areas? You're taking a hospital that currently sits within the most deprived areas, and you're proposing to move it to Belmont, and at the same time you are claiming to tackle health inequalities. The people I represent simply don't believe that to be the case. And when I hear people saying that really where you put a hospital doesn't matter and doesn't have any effect on health inequalities, if you spent more time listening to people in deprived communities, and I attended lots of the consultation meetings, and your account of those meetings is completely different to mine. And I think Agatha has mentioned this earlier on. If you spent more time listening, if you spent more time talking to people with the lived experience of inequalities and what that means, I think different conclusions would have been reached. And when it comes to describing that consultation as best practice, I understand that you can pay consultants to say just about anything you like, but my constituents say that that consultation was a sham and that the outcome was determined before the process began. And that's because of the umpteen attempts that have been made over a 20-year period to close that hospital. And at the end of the process, when COVID was gripping the country, one request that we made was, can we just pause before we make a final decision and look at the evidence emerging from COVID and how that impacts on deprived communities and what the evidence was? And the answer was no, we have to do this, we have to go ahead. And yet I now find that the whole program is being delayed, even though we didn't have time to think about that most important of events to hit the health service in 100 years. So one of the things I note is that this council has recently consulted and debated in this chamber the position of St Helier Hospital, and you need to be very clear that the council overwhelmingly believes that that was a wrong decision and is asking you to think again. I note that Ruth Dombey recently stated in a letter that her council's position, preferred outcome, would be that the hospital was on the St Helier site. We're not saying to change to rebuild or to modify the existing St Helier Hospital, but there was an option to build a new hospital on the St Helier site, and the difference between the two options was marginal, and we had an expert looking at that. So I'd be really interested to hearing your response, but I think there is a real sense that the overwhelming majority of the people in this borough, which is one of the boroughs most affected by it, is that what you are proposing to do is going to increase health inequalities. So how do you justify that?
So I think just first about what was reported in the Health Service Journal. I'm sure as many of you are experienced in dealing with the press, once they've put that out there, trying to get it corrected is never easy, but we did ask for a correction. I think it did go in. But once it's out, it's difficult to get that corrected, but we did go out and ask for it to be corrected. So I don't know what else you want me to say about that, but that's the situation we had. In regard to the health inequalities, we look at evidence, and evidence around health inequalities is around what access you have to good housing, education, and also local health in general practice and community. If the evidence pointed towards local hospitals doing everything, we wouldn't have in London some of the best stroke outcomes in the world, and neither would we have in London some of the best trauma outcomes in the world, where we actually drive past hospitals with people with stroke and go to specialist areas to look after these people. So local health services in acute settings, particularly where we are looking at bringing them together to have a more resilient workforce, an engaged workforce, a better workforce, looking after the most seriously ill patients in far better accommodation is what we have looked at and what the evidence shows us. I'm happy to take any more questions on that with evidence that you have around health inequalities and how that might change.
Just obviously have a question, obviously, in relation to the outline business case, the U Hospitals Programme. You're still waiting for feedback on that, aren't you? You've given a date of autumn for that.
Yes, I mean, we're in sort of constant contact with them.
Yes.
They've used that outline business case to provide inputs into the programme business case that's gone to the Department of Health and the Treasury.
Yes.
And then all of the schemes will then get feedback about what the next steps are on that basis. And we're expecting that imminently, notwithstanding obviously the fact that there may be a different Secretary of State by the morning. Yeah.
Secretary, yes. Yeah. Do you think this next patient that could well be delayed? Obviously, there's obviously a U Health Secretary there in place now, which will see the programme slip further.
I mean, it's impossible for me to predict, and I'm not going to try and predict the outcomes of political processes and what a new Secretary of State for Health might do.
Yeah.
I think what I would say is, we have very clearly identified an extremely pressing need for new estate for ourselves. The other schemes in our cohort within the New Hospitals Programme, the 8 Pathfinder schemes, have similarly pressing needs, and this is a commitment from government that has been through a couple of Secretaries of State already. So I think that on that basis we continue to press ahead.
And why has it taken so long for it to be approved? Obviously, given that it's approved in terms of moving the hospital to Belmont back in July 2020. This is over 2 years, 2.5. It could well be with further delays, maybe the autumn, maybe even next year. It does show considerable slippage in terms of the overall business case. I thought that would have been, gone hand in hand.
I mean, we've continued to press ahead wherever we can. We moved from the decision-making business case to the OBC quite quickly. We also moved quite quickly to a number of areas of pre-planning consultation, and have continued to have sort of extensive discussions around the, how we will build the hospital on the side. That there has been a process of bringing together and looking at these schemes in the round by the New Hospitals Programme. And looking at how this is going to be approached as a central government programme, and then a process that they have now been going through with within the Department of Health and with Treasury, and those processes take a certain amount of time, as this is effectively for the number of hospitals that are being built and the scale of the investment, a major national infrastructure program, and therefore has a certain sort of level and type of approvals that it needs to go through on that basis. Everything that is within our control as a local scheme, we are doing as quickly and effectively as we can. But equally, I think to get the benefits and to reflect the fact that actually this is a significant commitment of public money, there's a balance between that and the sort of central government processes as well.
There's also a chance the government could refer back the business case if it's not happy with what the programme outlines.
So the government was obviously, so various levels of government and the NHS were clearly involved in all the stages to this point. When we submitted the OBC, the draft OBC, clearly there was lots of dialogue and involvement at that stage. So there is nothing in any submission that we have made to the new hospitals programme and that has gone forward to the Department of Health and Treasury that is of any surprise to anyone. And that would be the case for all of the 8 Pathfinder schemes. They're all, at different stages of being pretty well developed, frankly. They are areas where there's a very pressing need, and that's been pretty well worked up. So there might be feedback. If there are, other conversations at central government level, then that's not for us. But I think it's in my view, it's unlikely to be a sort of pass fail. It's more a case of how do we continue to develop the scheme, and obviously that's a legitimate role of central government.
I just asked a cabinet member whether he knows whether we got a response back from the hospital, the leader, if you like to ask.
Well, what I can tell the committee is that on the 15th of June, the leader of our council wrote to Sarah Blow with a series of questions which have yet to be answered. There was an initial non-answer, I would say, followed by an astonishing comment that this wasn't the responsibility of the Integrated Care Board and that we should direct it elsewhere. The practice in this authority is if a letter comes in and it is directed to the wrong person, then we pass it on to the appropriate person for a swift response. It seems that from the 15th of June until now seems an extraordinary delay and somewhat discourteous to the leader of the council. So perhaps I could ask that be treated with the urgency that it should have been in the first place.
I've seen a number of pieces of correspondence. I would need to check with the ICS around that specific one and ensure that we've responded to all of the points that we're able to, Councillor.
Thank you.
Without wanting to go too much over the previous history of the consultation, can I just check one thing about the consultation? When you, I think there was consultation specifically with local GPs to see what they thought about it. And I wondered if there are any differences either between Sutton and Merton GPs, and whether any differences between Mitcham and Morden and Wimbledon GPs when you asked their views on the final proposal.
I can't remember whether we broke down the consultation so we could see the views of local GPs in isolation. I just can't remember if that was in there, and I certainly can't remember if there was a marked difference, if there was.
I just wanted to clarify a point that was raised that I think one of the councillors mentions that you could effectively have a consultant period where we reviewed the costs, reviewed the benefits of a development, and effectively prior to that happening, you could potentially they could already have their mind made up and potentially not be independent. I'm sure everybody on the council will know that professional advisors are independent and they have professional indemnity insurance. So I have full confidence that the consultation that was, or the advice that was received would be independent and would be fair, as is binding in the professional services community. But I just wanted to ask, just to check with yourselves as well, if that was your understanding.
Comment that I made about the accreditation of the consultation was the review bit that was done by the Consultation Institute. which was entirely independent of the consultation process itself.
Can I answer that? Because I made that comment and we were there. You were not. We were there. Quite a few of us actually heard them make those statements. I went to every single one of them and we were told basically Belmont is their preferred site. So if you're told that, it looks like basically we're wasting our time. People weren't listened to. Right, anybody else?
Right, okay. Yeah. I just really wanted to talk about the maternity services being moved to Belmont. Now, earlier you both admitted that poor housing conditions are a cause of deprivation, and you know, as Peter has pointed out, certainly in our ward there is a great level of deprivation and health inequalities, people in poor housing. Now, if those women are expected to go all the way to Belmont, I'm really concerned about their safety and the safety of their unborn children and newborn children, because it's a long way for them to go. They need those services actually on their doorstep.
So I think it's really important to emphasise that the element of maternity services that will move to the new site will be the labour ward and the birth centre only. So actually for the delivery event, the antenatal and postnatal services will remain on St Helier, where St Helier is where they're done. So the scanning will remain at St Helier, the antenatal appointments will remain at St Helier. And actually we run a huge network of midwifery services in other locations as well as St Helier, right the way out into the borough of Merton and into the other boroughs that we serve. And all of those will remain absolutely where they are. We do move them around from time to time. That's more about the availability of locations and making sure that we're putting those antenatal services as close as possible to those communities. So again, it's about saying, you know, there is, you know, in terms of midwifery, in terms of obstetric numbers, and in terms of the paediatric services, the children's and neonatal care that supports delivery itself, that does need to be consolidated. It needs to be in one place for us to be able to provide it in the way that we need to and that people deserve. But that is, you know, only one element of the care, and actually as much care as possible that can be provided locally still will be.
And really high risk women go to St George's. And I think you also heard Liz, our head of midwifery, say that we lose 2,000 women a year to either St George's or to Kingston because they don't want to come to St Helier, not because of the care, because the care is outstanding. I think you heard about the outcomes, the excellent outcomes our maternity unit does have, but because they don't want to deliver in the estate. So I think we've just got to understand that it's, you know, women of high risk do move to hospitals that are sometimes have more higher level obstetric care. Majority of women don't need that and are deliver locally, but women do move further away for higher level obstetric care, high risk obstetric care.
Thank you. That's the last question. We would like to put in a recommendation where Councillor Gould.
Yes,
all of the
earlier I
others.
think you were talking about the facilities at the new St Helier Hospital, sorry, in Belmont. What we'd like to know is whether you could bring to this committee an update so that the wider community could be aware of what is exactly going to be available at the hospital and at Belmont. I think that would, some clarification I think could be needed. Thank you.
I would.
Can I make an amendment that we reiterate our support for the critical care hospital to be located on the site of St Helier Hospital?
Who seconds that? Okay, I second you. Okay, we've got two recommendations.
So you would like to add an amendment to the recommendation. Could you just repeat exactly what it was you wanted to?
Yes, we reiterate our support for the critical care hospital to be located at St Helier Hospital.
Thank you. Thanks.
We still would like an update. Okay. Very much. Thank you very much.
Thank you very much for inviting us, and thank you for coming round
Yeah,
last week.
I should have thanked you at the beginning for having us round. So thank you for having us round. Hopefully we'll do it again. Okay,
More than welcome.
Very
thank
happy
you.
to. Thank you.
Right, we are now going on the Rowan surgery side. Who's going to be talking about that now? The proposed future of the Rowan surgery, who's talking about that?
Chair, it should be Mark Creelman. I don't know whether he's.
Is he online?
Yes,
Online. Yeah.
apologies, Chair, apologies. I was waiting to be let in as a panelist, so apologies because I'm at the New Horizons Centre following our public consultation and engagement event around the Rowans. What I'll do is I'll take the papers and the presentation as read, and I'll just kind of summarise what the proposal is. So firstly, we want to acknowledge that we're not where we would want to be with the Rowans and the current GP surgery, and acknowledge that over a long period of time, there's years of frustration around possible new builds, etc. So we just want to start from a place of acknowledgement. That said, the current contract with the current provider ends on the 31st of October, and they've indicated they do not want to continue with that. Now, we were working with that provider on various options, one of which was including an extension, but this was then their lead clinical GP served notice of resignation, and so therefore that was leaving the practice with no clinical leadership, clinical supervision, and that is actually leading to an unsafe service. So in terms of the current Rowans, we know these issues aren't new, but the premises are not fit for purpose and indeed aren't safe anymore. This current provider is unable to recruit any staff that are substantial and staying in the practice. And we have had, over the last 5 years, we've had 4 different providers try to make the Rowans work. At the same time, we have had a dwindling patient list. So probably in 2016, that patient list was around 9,000 to 10,000. It's currently just under 5,000, and we are seeing people vote with their feet and register elsewhere. So we are recommending that we disperse the list, which is basically shut down that practice and support people to re-register with surrounding practices, because we believe 3 things. You'll get better access to primary care, there'll be better continuity of service, and also there will be a better quality of care, because we are concerned with the current practice, and this isn't about the clinicians in it, it's about the quality and the safety of being able to deliver to the patients in the community. We considered other options. One was to extend, but the practice don't want to do that, and to re-procure, but that doesn't address the fact that actually the premises are not fit for purpose, and also because of the list of the size, we don't see that the new practice would be viable at this point. So we are in the series of engagement events. One was a face-to-face engagement at New Horizons tonight, which is where I'm at. We've got another virtual event on the 13th, and then a drop-in at the practice on Thursday where we can talk to individuals about their concerns, about their, their individual circumstances and what that might mean for them. Local practices around Rowans have all identified that they do have capacity to take additional staff and additional registered patients, and they do benchmark favourably with the national average around GP capacity. So the national average is around 1 GP per 2,200 people. and currently the practices around the Rowans, Figs Marsh, Wideway, etc., have an average of 1,500. So we do believe that the GPs have capacity. The other thing to say is that the funding for primary care follows the patient. So as patients re-registered, actually the funding that would go into those practices would change as well. If the decision is to proceed with the dispersal, we'd write to all patients, we'd have online and in-person registration, we'd identify with the practice those that are most vulnerable and support them in re-registering to another practice. And part of our engagement is actually asking people what they would need for a successful re-registration. In the longer term, and going back to my acknowledgement that this is not where we want to be, but in the long term, we are fully committed to a new primary care facility at Rowans Park. Now, that would not be a GP practice, but it would be a primary care facility incorporating GP services, primary care services, alongside community services, community health services. And those could be things such as cervical screening, immunizations, diabetes, postnatal care. And even on the previous conversation about some of the health inequalities, actually the new primary care facility can address and build services based on population need and the community need. So we would really want to work with local stakeholders, local councillors, local community organisations and local people in defining what the service portfolio would be in the new build. We think that the build is 2 to 3 years away. We are doing everything that we could possibly do to make that as speedy as it possibly can be. But we do genuinely believe that because of the size of the list, the staff recruitment issues, we cannot get staff to work there, or the practice can't get staff to work there. And also the state of the premises is that dispersal would be the safest and best option for the quality of care of individuals. Basically, the surrounding practices, again, we have mapped catchment areas to ensure that there's full coverage. It's just to say that it's not only a Merton issue, we have also been telling and in liaison with Lambeth practices, Wandsworth practices and Croydon practices as well, to make sure that actually they are able to take new patients if patients choose to go there based on catchment area, because obviously practices will only take people that are in their catchment area. We believe the new service model will improve access, more primary care capacity, wider service offer and a GP-led approach. It just won't be a GP practice. But we do also genuinely believe that the proposal to disperse is in the best interest of patients, because we believe that actually for continuity of care, for quality, for safety, for access, the best option is to disperse the list. So Chair, with your permission, I'll probably stop there, and I'm keen to get questions. And apologies, I am in a public building and I've got a funny feeling they're going to throw me out at 9 o'clock. So just to throw that in, and apologies for that.
Don't worry, Mark, we won't be questioning you at 9 o'clock. You need to get out as well. Anybody with any questions? Caroline?
Yeah, can I just ask, what are the plans for the site of the Rowan surgery at the moment for the future? Is it going to be sold off? Is it owned by the NHS? And also, this seems to be something that's happening across the country, where we see GP practices closing and these new hubs being brought in. So I don't know if this is a widespread issue. And also, could we understand a little bit more detail about what are you doing to help those people who live close by, those with disabilities and other issues that may need help to access other services? Thank you.
Okay, so a number of issues. Thank you for those. The current site isn't owned by the NHS. It's actually owned by Assura. And at the public event we were talking, and I think to Councillor Fraser as well, is that we can absolutely have the conversation about what their plans are for the current site with Assura and with our local councillors, and a joined up conversation about the future of the site. And I know that both the community centre and the Scout Hut are really keen to know about that conversation as well. So we would put that in place. I think in terms of the hub, what we are seeing is that we're seeing people's needs change, and it's not necessarily just about primary care and access to a GP. It might be access to mental health services. It might be access to podiatry services. And actually, the new build could genuinely be a very exciting build for the people of Mitcham, because we believe there, with the right engagement and working together, we can put a range of services that really are relevant to the local communities. Have I answered your question, Councillor? I think there's one bit that I've missed.
Yeah, just about the helping those in the community to access other GP services.
Yeah, so what we've within the public engagement events, we're asking people what support they would need. What we've already thought about is working with the practice and identifying those that are most vulnerable, ensuring that those most vulnerable people have a one-to-one conversation with us, and to ensure that we are supporting them in any way necessary. Now that might be, we've got within the surrounding practices care coordinators, and actually asking those care coordinators to work alongside people to make sure that they are transitioning into the new practice safely. And obviously when they get to the new practice, there would also be, you know, depending on their level of need, a review by the practice clinical staff. So what we want to do is ensure that people are transitioning safely. We would be asking the practice to identify those most vulnerable so that we can target that support.
I find, thank you for your presentation. I just find that all this seems to have come, we've all been made aware of this very suddenly. Were the councillors made aware that you needed a new GP surgery many years ago? Because with the numbers dwindling and the state of the GP surgery, you must have had plans on how to develop the site and thing. But I know, to me, unless I wasn't aware of it, it all seems to have been very sudden. And in the last month, you're suddenly thinking about a new GP surgery on a new site.
So I think the issues with the current accommodation are quite long-standing. So I don't think necessarily the issues haven't been known or talked about for many years, and I'm sure councillor colleagues would agree with that. I think in terms of the urgency around this decision, it's because not only have we received high levels of complaints around the Rowan service, and even in tonight's face-to-face, we got a number of kind of reflections on not being able to access a GP, not being able to get a service. And that's partly because we can't recruit people into the service, but also because of the state of the premises. Now, the urgency was also factored in by the resignation of the clinical lead, which means that actually as a service, it doesn't have that senior clinical oversight in place. Now, the current clinical lead has agreed to extend until the 31st of October, but that was a key decision in terms of the urgency. Now, I think that, you know, we would have wanted a seamless move into the new build at a later date, but unfortunately, currently, for the good of the residents, we want to ensure that there is quality, safe continuity of services now, and hence that's our proposal to disperse the list.
Yes. Hello. Yes, I just wanted to ask, you're saying that there are other GP surgeries in the area that have got capacity to take on all these patients. So really what I wanted to know was, with these other GP surgeries, how easy is it to get an appointment? If people ring up in the morning, can they get an appointment the same day? And that's with the current level of patients they've got.
So all the surrounding practices have same-day access. So if someone needs an urgent GP appointment, they should have access to that. The funding for primary care follows the patient. So if we saw a real swell in numbers going to one particular practice, we would work with the practice to ensure that actually their workforce reflected the need of those numbers. So actually there's we would see practices, say Tamworth may well recruit an additional GP depending on the numbers of people that transferred across. And really key to that is also allowing people choice in terms of which GP practice they want to register with, and us facilitating that registration. Did I answer all your questions? Is that? I don't know whether I can't hear. Apologies.
Can you take two questions at once instead of one question? Two people are going to speak so that you can respond to them.
Yeah, absolutely. Can you hear me okay?
Right, Martin and then Max. Okay.
I mean, I would like to obviously declare an interest as a nearby local councillor for Pollard's Hill. And obviously, you see in here, the Hugh Rowan surgery will form a hub for local residents. I'm sceptical that this will ever be built. This has been 10 years on the cards, this Hugh Health facility. It's like the Wilson Hospital. You've been promising that for years. Is this just a soft soap just to get through the consultation? But in reality, I'd be surprised if this is ever really built. And I think it's extremely disappointing that this has happened and that this decision has been made when residents had been promised this Hugh surgery at the Hugh Rowan site and back to 2010. So this is 12 years we're talking. You're talking about 2 or 3 more years. In reality, I think it is a disappointment for local residents, and I think there's no firm plans really to deliver this, and this is just something to get through this consultation and to offer something out there. But I'll be amazed if this ever takes place, given that this has been promised for years and you've systematically failed to deliver like promises made on the Wilson's Hospital to the people of Mitcham, and it's letting down people in the east of the borough yet again in the most deprived areas.
Apologies if you did cover this in your presentation. If from your perspective everything goes according to plan, when would the Rowan surgery be closed?
So shall I? I'll start at the last question and work backwards, and please to correct me if I've not answered. So the current contract ends on the 31st of October. So that's where the urgency lies, and the clinical lead has identified that they want to leave by the 31st of October. So hence that would be the kind of the transition date to new registration. So that gives us about 6 weeks to work with local residents to ensure that they're safely transitioning across. In terms of skepticism around whether it will ever be built, so I can completely, and started the presentation with an acknowledgement of the history that local residents, local councillors, etc., have experienced. All I can say is that we are talking to the developer. We have spoken to the local primary care network, who would be the new leaseholders, and all that is going in place. And so therefore we are really committed to this new build. I think if you put the new build alongside the Wilson or the East Merton hub that we refer to, and also the redevelopment in terms of the Collier's Wood practice, then actually we've got some real exciting developments within the next 2 years for the east of Merton. Going back to the Wilson, just to say that we had identified around £15 million worth of funding for an East Merton hub. Now, we did have a preferred site in the Wilson, and our local councillors and local council officers asked us to just reflect on that and actually work with them to see if there was any alternative sites. We're just coming to the end of that, and we will be presenting kind of the findings of that review to local councillors shortly. So I just wanted to say that again, we are trying to move forward with appropriate first-class accommodation in East Merton.
Thank you. So I just wanted to ask a question because it alludes to on here about even with extra funding, you're not being able to solve problems of building and staff, and therefore it appears that potentially financially it's this proposition that just is not working, potentially requiring taxpayer funding to support that. So I just wanted to find out from you what is the financial scenario at present?
Well, I think across the 4 providers who have covered it in 5 years, they have struggled financially to make the service viable. So actually have come back to what was the CCG or ended the ICB, saying that they couldn't really afford to run the services because actually the income that they're receiving isn't enough to generate the workforce to meet the needs. So I think that's probably, without going into the detail of finances, each practice has struggled financially to deliver a service from the current Rowan site.
Thank you.
Thank you. This has obviously been a long-running issue and an issue of concern. I just wonder whether there's been any reflection on what lessons could have been learned from kind of where we've ended up having to do something in quite a quick, quite a hurry to transfer patients. So just what lessons have been learned. And without going into the names, are there any other practices that you feel have similar problems that, if not managed properly, will end up in the same place?
Yeah, so I think having gone through this and spoken to local councillors, etc., I think there's probably a lot we can learn about how we engage and how we have the conversation early on about any kind of decisions and proposals that might be made. The urgency here really was about the GP resigning, but also the end of the contract and the difficulties the provider has had just in terms of delivering a safe quality services that again is also financially viable. So I think there are lessons learned. I think we would want to work with our local council officers and our local councillors in looking at whether there are any other areas. I wouldn't in a public meeting say that disclose if there were any areas that would that are of concern. We need to work through with the current providers and also work through with our local councillors what the plan might be going forward. So what I would say is, yes, we need to absolutely, learning is key to us making sure that we are addressing some of these challenges collectively rather than just a kind of NHS response or indeed a council response.
Do anybody else have any questions? Ellen?
So last one from me. So, so look, thank you for your comments so far. I certainly am fully supportive of long-term financially viable healthcare services, particularly when we've got a cost of living crisis and COVID bills to pay. One thing that comes to mind though is when GP services are more limited and they are further away, will that put off people from attending GP services to perhaps have checks done on smaller items or smaller health concerns that they might have if it's more difficult to get access to a GP service or it's a bit furder away from them, and therefore cause more risks to patients because of that slight reduction in accessibility to GP services?
So I think also just in terms of the surrounding practices, which are larger practices, and so therefore usually have a larger range of services.
Chair, the Wi-Fi at the New Horizon is temperamental from time to time. So it may be that Mark is experiencing that, as some members will be aware.
Sorry, I think I may. Can you still hear me?
Yes, Mark, we can hear you.
Can you hear me?
Hear you now.
So apologies for that. So I don't know how much of my how much of my answer you got, but I think what we would anticipate is better access to services. Yes, some people may have further to travel, but we do think that the benefits to the patients in terms of quality and safety will benefit patients on the whole. And again, the new build will be really exciting in that we can provide services such as screening, immunizations, mental health services that are kind of primary care plus, and actually therefore really meet the needs of the surrounding areas.
You've got two more questions, one from Councillor McCabe and Councillor Fraser.
Mark, thank you for coming along this evening, particularly when you've already done one meeting about the very same subject. I just wanted to share our conversation about this issue because when we first discussed this, we identified that the problems with premises at this particular surgery were first identified in 2008, and in 2012 the NHS gave approval for a development to go ahead, and in the meantime we have been talking in the same part of the borough, the east of the borough, where health inequalities are very marked, about the Wilson hub or the East Merton hub, as you described it. We've also had the debacle where the Wilson surgery was closed at short notice, and patients were sent to other neighbouring surgeries, only to find, having been advised that the surgeries would welcome them with open arms, that some of them were told, elderly people were told, that there was no room for them at the inn. And when you put it all together, the other thing I'd like you to confirm is that during the, Brenda Fraser, who of course is a councillor, a long-standing councillor for Long Thornton, and is with us this evening, has been fighting to get this resolved for years, and there has been an offer, as I understand it, from the council to make a financial contribution to the development of this surgery. And yet, despite all these things, we find that although the NHS talks about tackling health inequalities, people in Long Thornton ward are losing a surgery that's been regarded as unfit for purpose since 2008. The Wilson surgery was closed at short notice in very unsatisfactory circumstances, again in the east of the borough. And to come back to the point that Martin was making earlier on, people in the east of the borough feel left behind. They feel that the NHS talks about tackling health inequalities, but you will be judged by what you do, not by what you say. And I think it's really important that the NHS gets the message that you cannot ignore the issues of the people living in that part of the borough. They need better services, not to have services taken away. And come back to what we were talking about in the earlier item, St Helier Hospital, to my mind, is in exactly the same category, because deprived people feel that local services are being taken away from them rather than provided for them.
So just to kind of reiterate our commitment to the redevelopment. So I understand and acknowledge that actually there's been a number of reasons why the frustrations over the last 10 years about the new build, and Some of that is the sale of the land. Some of that was about the developer pulling out, etc. There are numerous reasons as to why things didn't progress when they should have. In terms of the people of East Merton, I think that's exactly what we're saying in terms of the dispersal. I don't think it's about the loss of a GP practice. I think it is about ensuring that the people of East Merton and the people surrounding Rowans Park have access now to quality services. And that's the real concern here around the current provision. And the meeting that I've just come from kind of confirmed that for me, because actually what people were saying is they couldn't get an appointment, they couldn't see a GP. When they did see a GP, it wasn't the same person. There was no continuity of care. So they have really struggled with access, continuity of care and quality. I think in the short term, this will provide better quality services, more continuity. And in the longer term with the new build, you're absolutely right. The proof's in the pudding, isn't it? So we have to act and make sure that we make that happen as quickly as we possibly can. And the 2 to 3 years is a guide. We are trying to get onto the backs of the developers, onto our GP practices as well that are surrounding it, are going to take on the lease. Actually, let's get on with this and let's show people that we mean business with this new facility and get on with it.
Brenda, you have to be quick because he needs to get out.
I'll be very quick. Mine is not a question. Mine is actually a comment on the situation. I was invited here. I'm not really part of your situation, but I have been part of the health scrutiny for years. I've lived at in Long Thornton Ward since 1981, and that's when I joined that surgery. It was an absolutely phenomenal place. It was fantastic. Most people wanted to go there. It outgrew its work really, because it was situated on Rowan Road, a very small surgery. So they moved to Stirling Close in 1995, which was newly built, a fantastic place as well. And everybody wanted to go and register with them. But it outgrew its use and was too small. On the Rowan site itself, which was a school for those who don't know, and you should take a walk one day. And I was really angry with CCG for most of them don't know where this place is, because you can't be making comments on somewhere where you don't even visit. And they plan to come with me to see it, and they haven't been yet. And Mark knows that. He knows how I feel as well. I was at the meeting this evening, and the place was packed with people, and our MP was there. And exactly what you've been asking about and talking about were the same things that came up. There was no reason to leave it to fall down, that the place is being used as a dump, and I've reported that. It's for fly tip. People put their all sort of rubbish in the place. I reported to the doctors involved at Wideway, because they're the main ones dealing with it. And I don't know what happened, but it was kept like that. There's complaint about the receptionist not speaking, but in fact, I've actually made it my point of duty, as Peter said, to walk around, find out what's going on, contact the right people, got a note put up to explain to patients, don't go to ask for anything here because there are no doctors here. And finally, we've got to this point. I'm not angry about the medical center so much as I'm angry about how it has been done. None of us as councillors have been spoken to. It's just worked out, and finally we got this note that this is what we're going to do. And I said, I don't think so. We need a meeting. And that's how we've had this paper with the meetings, tonight being the first one. It should have been on the 16th of last month, but because of the situation in Galpin Road, it wasn't possible. And I think most of us understand that. There are 2 other meetings, and it's all on the paper. That one is a drop-in, and that will be at the Rowan surgery. How that will work, I don't know, because the place is a dump, really. Virtual meeting will be on the 13th. And that one will be on Teams for those who use Teams or have access to it. But the main bit that Siobhan, myself, and most of the people were angry about is the fact that the Rowan site was sold as something really out of Mayfair, really. A pond, beautiful setup, everything. And those people who bought their houses were duped. And most of them are selling the place off now because they didn't get what they asked for. 2 weeks ago, I asked what's happened to the community center and the Scout Hub. And it was as if they never existed. And I said, it's not going to work. We had 100,000 given to us for still money. And then it went down to 90, then to 70. And that money, nobody seems to know where it is. And we need to find out where it is. The same story coming up and again. And so I have no intention of giving up at all. I'll fight this to the bitter end because we deserve to have what we have. If it's going, what we've said is if it's going to be a medical center, I have had 30 years in the health service and 15 years teaching health. So I know what I'm talking about. If it's going to be that, we do not want receptionists, physiotherapists, occupational therapists, and no doctors. And so we're told that we probably will have a GP. So we'll be holding them to that. You must have somebody with medical knowledge that when people turn up, if anything happens, they know what to do. And so that's why I've been asked to come here tonight. So this is my second meeting for the night on health, and we will fight it to the bitter end.
Thank you, Councillor Fraser. Mark, have you got anything else to say? And you can go because they're going to lock you out in a minute.
Just to reflect on, and again, acknowledging a lot of what Councillor Fraser raised. We did postpone the previous meeting because of the Galpin Road incident, the tragic incident, because we thought that was the right thing. But we did also kind of communicate with that with councillors and council leader and the local MP that we should postpone it for 3 weeks to allow people to kind of catch their breath from the tragic event. I do think in terms of the new build is GP-led services, so it absolutely will have GPs at the helm of the services, but we want to work with the local stakeholders, local community, local people, local councillors such as Councillor Fraser in actually what does that look like for the local residents of Rowans Park. So I do again go back to the rationale for doing this is about quality of care, continuity of care, access now for patients, because we are hearing a multitude of complaints about the current service, and actually we are really focused and committed to the new build.
Thank you very much, Mark. I'd like to tell you that the east of the borough, the residents, because I live in the east of the borough, majority of the residents feel that they're a good meal ticket because everybody uses the east of the borough as an excuse to get funding and nothing gets done. Yeah. So if this is going to get done, you have to do something so they can eat their words. And thank you for coming tonight.
Okay, thank you.
Chair, I think you need to let Mark Creelman know that he's okay.
Mark, you can go. You're free to go. Otherwise, you'll be locked in.
There was an ICS paper.
Oh, you're on this one. Oh, sorry.
The integrated care system paper.
I thought it was Dagmar. Okay, do you want to do it quickly?
Sure,
Can you speak to them so they don't lock you out?
Yeah, so
it's 5 to 9 now.
It's 5 to 9. Maybe if they try to chat me out, I'll just take my computer out and do this outside.
No, if you speak to them, they'll be kind to you.
Okay, so just in terms of the the integrated care system, it's basically a partnership of organisations to join up and deliver services that improve outcomes for our residents and our population, tackle health inequalities, enhance productivity, but also start to expand the kind of health and social care into areas such as housing, police, economic development, so that actually we're really talking about things at a system level as well as a local level. Now, the ICS, the Integrated Care System, splits itself into two governing boards, really. The Integrated Care Partnership, and that's exactly what it says on the tin, is a partnership. It has Health and Wellbeing Board chairs. It has the representatives from the voluntary sector, Health Watch, etc. And then there's the ICB, the Integrated Care Board, which is the NHS part of the system. So the NHS part of the system then delegates its responsibility and its finances down to 3 places. Some of it will stay at South West London, a small part, such as specialist commissioning. Some of the money will go to our provider collaboratives, so acute services will kind of get their budget to run acute services. And then the rest of the delegated authority and the budgets will come down to place, and place is Merton, just in terms of the language. And there we really are, we've established a committee, and that committee is focused on developing neighbourhood services across sectors, joining up as much as we possibly can, addressing the needs of the local population, and consider work and links into other areas. I think, a number of people have mentioned housing today. How do we improve housing together, collectively, to improve people's health? So we have established a borough committee. It will focus on residents, it will focus on inequalities. It wants to be open and transparent, and I accept some of the comments from the previous presentation that really what we need to do is ensure that we are working together in a completely open and transparent way. But it will sit alongside the Health and Wellbeing Board. And also, we also already have the Merton Health and Care Partnership. So we will align the committee with that partnership and over time, perhaps simplify our governance structures. Key to this is the local delivery of the health and care plan, which focuses on start well, live well, age well initiatives that are preventative, that are joined up, and that really have an impact of us working together. So basically, within that, we've provided you with kind of the members of the local committee. Some of those are your officers within the council, and we've kind of stretched out what the current governance looks like. We are proposing a workshop in October around the ways that we work together, and officers, etc., will work with us on that. And we should extend that, I think, to local councillors as well, to ensure that the Health and Wellbeing Board and the ICB Borough Committee really there. I'm just really aware that I thought I'm going to get turfed out in 3 minutes.
Could you explain where this committee fits in amongst all of that? And would you be how can we be ensured that we have scrutiny across the board? And it doesn't seem that there's many councillors involved.
Okay. So actually, the Borough Committee and the Merton Health and Care Partnership will absolutely feed into the Health and Wellbeing Board. The overview and scrutiny. We will update as requested, just in terms of some of the initiatives and also the progress against the health and care plan. So just to say that both, the overview and scrutiny is a statutory function, as is the Health and Wellbeing Board. So what we're not doing is replacing those. What we want to make sure is that actually we've got one plan for Merton, and that we align what's happening in the Borough Committee and the Borough Partnership with actually the strategy from the Health and Wellbeing Board and actually the scrutiny of this committee and others. I'm sorry, I think I might.
You're free to go. Can you give us an update for the next meeting?
Yeah, so what I'd propose to do is, rather than it be just around the governance, I think perhaps actually some of the initiatives that we're dealing with at a borough level, particularly around inequalities. We've got some reports going to the next Health and Wellbeing Board, but actually we could absolutely bring an update to the next overview and scrutiny.
Thank you. Good night.
Good night, thanks very much, and thank you for accommodating me jumping around remotely. Thank you.
Right, Agmal, I think it's you.
Thank you, Chair.
He's doing it now.
Thank you, Chair. So this is an item which is essentially an early look for the panel at a major upcoming commissioning exercise. So our existing home care contracts have just over 2 years to run, although there are opportunities to end the contract earlier than that if we chose to. And clearly home care, particularly for older people, is an incredibly important key element of how we respond to social care need. And it's a critical component of enabling people to remain in their own homes for as long as possible, and to remain in their communities for as long as possible. So what the paper does, and I'll take the paper as read, but what the paper does is it summarises the current contractual arrangements. It notes that those current arrangements have generally worked reasonably well. The home care market nationally is a very fragile market, particularly so in London, but we've managed to maintain capacity and maintain delivery at a local level. But we are starting to see more and more challenges around that as the workforce issues become greater for providers, cost of living, cost of running a business increases, that kind of puts challenges on providers. So we are starting to see some of our smaller providers struggle to respond when we need them to respond. So there are some kind of cracks beginning to show in the existing arrangements. But what then the paper goes on to do is just talk about some of the ways in which we might want to think about a slightly different model for the future, and also identifies a number of key issues that we will need to determine before we commence any commissioning process. So as I say, it's an early opportunity for the panel to be aware of the fact that we will be recommissioning these services at some point in the next 2 years. And that may be something that the panel would want to give further consideration to as we move through that process, in terms of, for example, getting updates on the new service model that we're proposing to commission against service specification and so on. I'll stop there, Chair, and take any questions, comments.
Thank you. As you know, Chair, in the Lib Dem group, we've been very keen on paying our care workers the London living wage. We brought a number of motions about this to council over the last few years, including one fairly recently. And therefore, I'm slightly surprised to read in 6.2 about this. So my understanding was the council has agreed to pay the London living wage, and therefore that's something that should be built into our tenders, and it shouldn't be something that needs to, I mean, by all means, of course, we should note it, but it shouldn't be something that we need to bring up for discussion again. And therefore, I would like to add to our comments or recommendations on this that we reiterate that we want our outsourced care workers from these providers to be paid the London living wage. Thank you.
So I just wanted to hear a little bit more around your proposals, because I understand as well that there are different funding pots for different residents of care homes. So some may well be part of a hospital and then move into a care home. And there are different fees that are paid by that. So I've always been an advocate of a sort of a single flat fee that's paid, rather than several different pots and care homes receiving funding from different parts of our sort of group funding, our healthcare funding pot. So really keen to understand, and I sort of understand your point as well regarding London living wage, but the cost of care is extremely high. And we need to actually find some more efficiencies in the funding package by potentially working closer together with clinical commissioning groups as well. So I'd love to hear your thoughts on that.
Okay, thank you, Chair. So in relation to the London living wage question, the council isn't yet a London Living Wage accredited organisation. My understanding is there's a paper going to Cabinet this month that will seek agreement to become an accredited London Living Wage council, and that would mean that we could either choose then to amend the existing contracts to pay London Living Wage, or we could do that as part of the recommissioning process, so that we would introduce London Living Wage as part of that process. And there is a significant financial impact in excess probably of £1 million a year to implement London Living Wage. But just to be clear, it isn't the current policy of the council to tender all contracts on the basis of London Living Wage, but that it may become the policy of the council following Cabinet this month. And
well, I'm afraid I don't think his response is correct. The council, I think you should look at the motions that the council has passed specifically on these care workers and our desire for them to be paid the London Living Wage. So I don't think that what you've said is absolutely in line with my understanding. So I would ask you to go back and have a look at the motions that the council has passed. I haven't heard any opposition in the council from any colleagues and any of the parties to paying these people who do this very important job, the London Living Wage. So I'd ask you to go and have a look at that, and then hopefully we'll agree to add to our recommendations to you or to the Cabinet, whoever they're going to, that that's what we should be doing, just in case there's any doubt about it.
I think you should give him time to go and have a look at it, because he said it's coming to Cabinet this month. So until we know what's coming to Cabinet, I don't think there should be a recommendation until, because there's already a recommendation. So if it doesn't come to Cabinet, which, yeah, well, if they do, then they'll do something about it, won't they? So,
well, then I would like, sorry, perhaps we should finish it. Any other comments on this? But I would like to have a proposal that we should add something and have a vote on it.
so, Chair, just to answer the other question, I think so. So this is a commissioning exercise in relation to home care, not care homes, and yes, there are complexities around the way in which care home funding is in place, and there are often social care contributions and health contributions, particularly where there's nursing care involved, and sometimes joint funding arrangements that are really quite complex. There is we're in the process of undertaking a nationally required exercise in relation to determining fair cost of care, and the local proposals around that will be going to Cabinet in October, prior to being submitted to Department of Health and Social Care in the middle of October, and that is precisely about moving towards, over time, a model where there's a better balance between publicly funded care home fees and privately funded care home fees, specifically to address that issue about disparity.
that's me.
So that is something that we would want to discuss with providers. There have been a number of ways in which this has been tried in the past in other areas, and it hasn't always been particularly successful. So I think it's something that we would want to think quite carefully about. But essentially, not to put too fine a point on it, there is a financial incentive for home care providers to maximize the amount of care that they are delivering in order to maximize their cash flow. And if we want, so we have a very successful reablement model. So when people come out of hospital, we have an in-house service that works with them for up to 6 weeks and helps them to regain as much independence as possible. If at the end of that, and quite a few people at the end of that 6-week period don't require any ongoing care because they've regained their independence to a sufficient level. for those who do need ongoing care, what we want to try and avoid is that you increase someone's independence and then they move to a home care provider and it drops off again because the home care provider is doing things for people, not supporting them to do themselves. But over time, if the home care provider was doing that successfully, the amount of care that individual would need would reduce, reducing the provider's cash flow. So if you like, it's a perverse incentive to keep the maximum amount of care in place. What we'd want to explore is, are there ways of, for example, agreeing to continue funding some additional hours for a number of weeks, so that the provider's cash flow was managed in a better way. It's different ways of trying to make sure that the provider has enough security in terms of cash flow and ability to pay their workforce and so on, but also feels confident enough to be able to reduce that care over time. So it would be exploring different ways of achieving that.
So just to add a comment, and I find I think it's really great that you're reviewing this, because there certainly seems to be a movement in the market more towards home care services, dom care, rather than into care home services. So I think it would be great to hear more around how you're working with the private sector as well, because of course we've got huge care groups such as Anchor Trust, who are extremely predominant in the area. In fact, I think they did quite a large acquisition with social housing as well, to try and bring care more into people's homes, more on their doorstep, more of a way of living. We've got a rise in independent retired home living services as well. And certainly that seems to be the way that the future of the private healthcare market is going. And it'd be great to hear about plans to work more closely with the private sector, such as other charities like Anchor Trust, to try and build a collaborative service with them.
So absolutely, we would be looking to work in terms of designing the new model and delivering the new model. We'd be looking to work with a range of independent sector providers, whether they be private sector providers or voluntary and community sector providers. What we're also very interested in, I think, in doing is looking at ways in which we can support local business to grow and to be competitive in terms of winning contracts. One of the home care and the delivery of home care is the same wherever you go in lots of ways, in the sense that what matters to people is that their carers turn up on time, that their carers stay for the length of time that they should do, that they do the tasks they're meant to do, and that they're courteous and so on and so forth. What makes home care in a particular area unique is that it's able to respond to the individual characteristics of that area. So the ethnicity of the population of an area, the language preferences of the population of an area, and so on and so forth. So there's a balance to be struck between big national organizations and the innovation and efficiency that they can bring, and smaller local organizations that can perhaps have a better understanding of the specific needs of their community. So I think it's not a one size fits all. It's about working with different size providers to get the best of all worlds, hopefully, or at least the best compromise of all worlds.
Thank you, Chair. I would like to add under our recommendations an additional recommendation B, that it should be made a contractual requirement that care workers be paid as a minimum the London living wage for contracts to be let as part of this process.
I'd like to second that. Thank you.
Can I make an amendment? It obviously should be subject to the forthcoming cabinet paper.
I disagree to that.
Things are properly budgeted for as well.
No, this is a recommendation to the cabinet.
No, I'm amending it.
So you're voting it just to
I'm
be clear.
I'm amending.
You're saying that if the cabinet doesn't agree,
I think the cabinet has to consider that, obviously, in line in terms of financial implications. I'm not saying no to it. I said obviously subject to the cabinet. We need further information to be provided.
So just to be clear,
No, I've just
Many of
said,
these
I have been
workers
very
work in the
clear,
east of
Councillor
the borough.
McGrath. I am very
Can
clear,
you
Councillor
You
McGrath.
are worried about
Subject, I haven't said
inequality.
no, Councillor McGrath. I said subject to the cabinet.
We
paper
should be
because
making
I
a
want
recommendation
further-
to the cabinet.
I want further
Their
information.
job is to sort out.
Simon, if you want, we'll take a vote.
I
They're
can,
not,
I
they're
will
not, they're not saying,
not
it's
accept
not
that
saying no.
amendment.
Yeah.
Yeah.
It's not
so-
saying no. Right, choose for Simon's.
Voting on the amendment.
No, okay, no, we're voting
We'll vote
Simon.
on Simon
Yeah,
and
and then
then
we'll
vote on
put
the
the
amendment,
amendments, yeah.
So we're voting on my amendment.
For the
The
London
lo-
living
That we
wage,
should recommend
recommend.
that these contracts be let at the London living wage as a minimum.
Can I move mine as a motion then?
Yes,
Okay,
Yeah.
yeah.
so I've no idea, I'm afraid, what we're
Against,
voting on.
against,
Yeah, we'll move a motion. I'm going to move a motion that we have it subject to thing if you don't accept the amendment.
Yeah,
So, yeah.
you don't. I want him to give the thing a chance first. Right,
Who's seconding?
Second, yeah. Can I move a motion?
yes,
That obviously that the same recommendation, but obviously this is be subject to consideration of the forthcoming cabinet paper and the full financial implications for the council.
right, vote.
So I shall be
And who's abstaining?
We've had a motion. I said voting for this motion.
No, you're down, but the other, Simon's abstaining.
Who's against and who's abstaining?
She's abstaining. Jennifer's abstaining, Simon's abstaining.
So then it's carried.
Carried, yeah. Any more questions for Keith? Dagmar, do you have any updates for us? Okay. All right, now say good night to everybody. Thank you all for coming.
Well, no. We haven't said no. We haven't said no to it, and it's